Hello, guys. Welcome to you all to our sessions. Today, we are going to start the endocrinology. Endocrinology is very important for MRCP for both part 1 and part 2, and you will get near about 19 questions from this topic. So, we have to learn this endocrinology very good. Okay, and endocrinology is little bit tough, I think, and little bit very tricky. If you read this very carefully, I think you would able to answer these questions very easily. Now our first topic is diabetes mellitus. In diabetes mellitus, we know that there are two kinds of diabetes, especially in type 1 and type 2, and others are variety like gestational diabetes and others. So now first come to the type 1 diabetes. You know that type 1 diabetes is an autoimmune disease, so autoantibody should be present here, and it is a T cell mediated disorder. And the antibodies are usually against the two antibody, actually, that is the one is islet associated antibody and glutamic acid decarboxylase antibody. In type 1 diabetes mellitus, we usually find ketonuria in this patient. So if you get the ketonuria and antibodies, that is the islet associated antibody and glutamic acid decarboxylase antibody, then it is certain that this patient has type 1 diabetes mellitus. And ketonuria usually is not present in type 2 diabetes mellitus. And you can see here only 10% patient may have the positive family history. And in case of type 2 diabetes mellitus, it is more expected that the familial association. And in here, ACLA-DR4 is very important association in case of type 1 diabetes mellitus and also DR3, but DR4 is more important, and this is very important for our part 1 exam. Okay, now come to the type 2 diabetes mellitus. In type 2 diabetes mellitus, we know that there is relative deficiency of insulin. That means insulin is present in the body, but it's not working actually, and the sensitivity of the insulin is reduced. That's why in our blood there is more glucose. And also in type 2 diabetes mellitus, there is a very association of familial origin or familial association, and in the identical twin, it is 100% concordance in identical twin. But in case of type 1 diabetes mellitus, there is only 40% association in between the twins, and there is no, importantly, ACLA association. So now come to the point, how could I diagnose this patient of diabetes mellitus? In WHO criteria, if the fasting glucose level is more than 7 millimole per liter, or random blood sugar level more than 11.1, and 2 hours after OGTT if it is more than 11.1, and additionally hemoglobin A1C if more than 48 millimole per mole or 6.5%, then we could assume that this patient may have diabetes mellitus. So then we have to look for the clinical symptoms. If the patient is symptomatic, then if you got this kind of lab investigations positive, then you can say this patient has diabetes mellitus. But if the patient is asymptomatic, then you have to do another test in separate occasions, this test. If this is positive in that test too, then you will call it definitely diabetes mellitus and you have to treat this patient. Okay, and you know that in case of hemoglobin A1C, actually it is a summation of, or it shows the average blood sugar level in 2 to 3 months back, and we will know it about it in later in a good way. Okay, now come to the point in impaired glucose tolerance or impaired glucose regulations. It is called pre-diabetes, and it's very common in our life. You can see that in UK, about 1 in 7 adult may have insulin glucose tolerance. So when we will call it insulin glucose tolerance impaired, that is, if fasting glucose level is 6 to 7, 6.1 to 7, then we will call it impaired fasting glucose. If the blood sugar level is 7.8 to 11.1, then we will call it impaired glucose tolerance. And in case of impaired glucose tolerance, here you can see that impaired fasting glucose means due to hepatic insulin resistance. And in case of impaired glucose tolerance is due to muscle insulin tolerance. Okay, so it's important for pattern exam. Another important thing is that triglyceride is the very strongest independent risk factor for cardiovascular death in case of diabetes mellitus and also impaired glucose tolerance. And it increases the mortality rate of the people. So if the diabetic patient has increased TG level, so we have to treat this very promptly. Okay, impaired oral glucose tolerance test is not necessary for our exam, so you should read just in yourself. Now come to the hemoglobin A1C. As I was talking, that hemoglobin A1C is a summation or average of blood sugar level in the 2 to 3 months back. So hemoglobin A1C may indicate the actual blood sugar control of a patient. So we have to do this test. As it has association with hemoglobin of our red blood cell. So if there is any changes of the red blood cells lifespan, so it will affect this test. Like if the red blood cell lifespan is increased, so this will we will get higher than the expected level of hemoglobin A1C, and if it is lifespan is decreased, then we will get lower than the expected level of hemoglobin A1C. So this box is very important for our part 1 exam. So you can see here there is a list of lower than expected level of hemoglobin A1C due to reduced RBC lifespan and higher than the expected level of hemoglobin A1C due to increased RBC lifespan. So what are the causes? Firstly, lower than the expected level of hemoglobin A1C, here sickle cell anemia, glucose 6-phosphate deficiency, hereditary spherocytosis. So all these cause hemolysis. So then hemoglobin and RBC lifespan will be reduced, and subsequently the hemoglobin A1C will be lower than the expected level. And additionally, chronic liver disease, splenomegaly, and hypertriglyceridemia will be responsible. In case of higher than the expected level of hemoglobin A1C due to actually the increased lifespan of the RBC, that is the iron deficiency anemia, vitamin B12 or folic acid deficiency, alcohol dependence, chronic renal failure, and hyperbilirubinemia, and additionally splenectomy. So this will cause increased lifespan of the RBC. Okay, so this chart is important for part 1 exam. Now come to the another box here, that is the if we treat this diabetic patient, what is our goal actually? What is the target hemoglobin A1C for this patient? If we treat the patient with only lifestyle modification, then the target should be 48 millimole per mole. If we treat this patient with lifestyle modification with metformin, then the target should be 48. And if patient in on any drug that may cause hypoglycemia, so target should be 53 millimole per mole. And suppose this patient on any drugs but hemoglobin A1C is risen to 58, then our target should be 53. So there is a formula actually. You can measure the blood sugar level on the hemoglobin A1C by calculating, like if we multiply this hemoglobin A1C by 2 and if we just minus 4.5, then we will get the average blood sugar level of this patient. Okay, now come to this point, diabetes mellitus, management of type 2 diabetes mellitus. Firstly, in type 2 diabetes mellitus, we have to give dietary advice. And another important thing is that in case of impaired glucose tolerance, there is no evidence to treat this patient with drugs. only you have to give the dietary advice and lifestyle modification. And also in case of type 2 diabetes mellitus management, firstly you have to give dietary management and exercise of this patient, and then you have to give the drugs. So what should be the dietary advice? You have to encourage this patient with, he have to take more fiber, low glycemic index sources of carbohydrate, include low fat dietary product, dairy products, and oily fish. You know that in case of oily fish, there is abundant of HDL, that is the good lipid, and this patient should take this. Control of intake of foods containing saturated fat and trans fatty acids, and limited substitution of sucrose containing foods, and discourage of use of foods marketed by specifically at people with diabetes. You will see in your ward that some company will advertise this kind of food for the diabetic patient, but NICE guideline doesn't recommend it. And the initial target weight loss should be 5 to 10% of this patient. Okay, now come to the hemoglobin A1C. We discussed about it. Actually, it is the average blood sugar control of this patient of the previous 2 to 3 months. And in case of control or treating this patient, we have to measure the hemoglobin A1C. Firstly, in every 2 to 6 months until the stable of the patient. When the blood sugar will be stable, then we have to measure this hemoglobin A1C 6 monthly. Now, blood pressure control. Blood pressure control is very important for diabetic patient. As you know that if the patient has high blood pressure, he or she may have chronic nephropathy. So we have to treat this blood pressure very urgently. So what is the initial target of this blood pressure control? There are many actually the references of the target of this blood pressure control, but we have to maintain this patient with 130 by 80. Usually in all other cases the initial blood pressure control should be 140 by 90, but if in case of diabetes with hypertension, then the target should be 130 by 80. And we have to use AC inhibitor or ARB for this patient, because it will not only the control the blood pressure, but also it will reduce the microalbuminuria or proteinuria of this patient. Now, the algorithm for drug treatment of this diabetes mellitus. In case of type 2 diabetes mellitus, we can give so many options, but in case of type 1 diabetes mellitus, we have only one option, that is the insulin. So in case of type 2 diabetes mellitus, you can give the Metformin or other oral anti-diabetic drugs as well as insulin. So our first line drug should be Metformin. Metformin is an excellent drug, and we have to try this drug first. And if it is not controlled by Metformin, or Metformin is not suitable for this patient, then you can give sulfonylurea. And others drugs like thiazolidinedione or DPP4 inhibitors we can give also. So in case of Metformin, if it is not suitable for him or it's not controlled with Metformin, then we will give additionally the sulfonylurea. So what are the sulfonylureas actually in our practice? Commonly we can give the gliclazide, glimepiride, and glipizide. These are the very well practiced sulfonylurea in the market. Other sulfonylurea has so many complications and more chances of the hypoglycemia. That's why these old drugs are not used right now. Only these 3 drugs are very recommended for the treatment of the diabetes mellitus. In case of sulfonylurea, the highest dose should be in case of gliclazide, that is the up to 160 milligram, and in case of glimepiride it should be up to 6 milligram. And additionally you can give the DPP4 inhibitor, thiazolidinedione of this patient, and we will learn about this in later. So now come to the meglitide. In case of meglitide, that is the repaglinide, it's very common, it's very similar to the sulfonylurea, and its mechanism of action is very similar to sulfonylurea. They act both on the ATP dependent potassium channel, and it may cause the hypoglycemia, but it is not likely as the sulfonylurea. If this patient has erratic lifestyle, like he or she often forget to take the drugs, that is the before 30 minutes, then you can give this drug to this patient, because it can be taken just immediately of the taking meal. And in complications, it has also may cause hypoglycemia as like the sulfonylurea, but lesser. So if this patient has hemoglobin A1C more than 7.5%, then you can consider insulin therapy. But before insulin therapy, there is another option, that is the exynotite. So we can give exynotite in diabetic patient, especially if this patient is very obese patient. BMI, if BMI is more than 35, then we can give exynotite for this patient. You know that insulin has insulin like growth factor effect, so weight gain is a very common complications of insulin therapy. So in case of obese patient, if this BMI is more than 35, so exynotite is a very good option, because it will reduce the weight of this patient. So it is very important and very good drug. And if you give this exynotite to a patient, there are some criteria that you can measure whether this drug is appropriate for this patient. It is very expected that in case of exynotite, if we use exynotite, so this patient's hemoglobin A1C should be reduced more than 1%, and the weight of the patient should be reduced more than 3% at 6 months. If it is not with this exynotite, then we can call it that exynotite is not working for this patient. Now, insulin therapy. If insulin therapy is imminent, then we should give this insulin therapy for this patient, and if the hemoglobin A1C is more than 7.5%. There are a lot of insulin regime in our market, like ultra short acting, or regular insulin, intermediate insulin, or long acting insulin. So in case of our GP practice or our in the outpatient department, in case of insulin therapy, the intermediate insulin therapy is a very good options, like isofen and intermediate acting insulin, lenti, like this. We can give it in bedtime or twice daily according to the need, and those should be 0.2 unit per kg, and in starting with the 10 unit, and you have to increase this in insulin in 2 unit per 3 days up to the stable of the blood sugar control of this patient. So in case of long acting insulin like insulin glargine, there is an anatomical point in here, like in case of glargine, there is amalgam of glycine and arginine. So glycine will be at the position A 21, and 2 arginine should be in the position B, in position B 30. So it's little bit important for part 1 exam. And in case of intermediate acting insulin, there is a very common complication for this patient, like nocturnal hypoglycemia. It is more common in intermediate acting insulin. You know that in case of intermediate acting insulin, this insulin acts throughout like 10 to 12 hours. Suppose this patient has taken this insulin in the night, that is the near about 9 p.m. or 10 p.m. But when he will sleep, so in the very early morning, there is no food in the stomach, but insulin is still working. So there is a very good chance of hypoglycemia of this patient. So in this case, we have to advise the patient that you should take some snacks in the early morning, and or we can substitute this intermediate acting insulin with long acting insulin. You know that in case of long acting insulin, the insulin release is very slow, so there will be no chances of nocturnal hypoglycemia. So it is very important for the exam, this complication. Okay, and we know that in case of hospital admission of this patient, if we want to use the insulin, basal bolus regime is very good option for the patient. Like you have to give a long acting insulin at night and regular insulin in 3 times of the day. That is the basal bolus regime. Okay, then come to the lipid management of this patient. We know that in case of diabetes patient, it is very commonly we found that increased level of TG and others lipid, and it has a very good. It has a very mortality. It will high the mortality of or mortality rate of the diabetic patient. So there is a target of lipid management of diabetic patient like 4 to 2. That means the total cholesterol should be less than 4 millimole per liter. LDL should be less than 2, and TG should be less than 2 or 1.7. So it is our initial target. So we can give this atorvastatin to this patient. If it is not controlled with atorvastatin, then we can add the ezetimibe. If it is not controlled with them, then we should add the evolocumab of this patient. Okay, so now I will learn about the drugs part by part, and it is important for the exam. Now we will learn about metformin. We know that metformin is a begonite variety or class in classification. Its mechanism of action is to improve the insulin sensitivity, and it will reduce the hepatic glucose output. So in case of type 2 diabetes mellitus, it's the very fantastic drug, and we have to use this drug as a first line therapy. And importantly, this drug doesn't cause hypoglycemia like the sulfonylureas, and also it will reduce the weight gain. Sulfonylurea will increase the weight, but metformin will decrease the weight. So in case of obese patient, metformin is a very good drug. But there are some adverse effects of this metformin, like very commonly GI upset, and also nausea, vomiting, diarrhea, intolerability of this 20% patient. It is a very common complications of metformin. So what should we do in this situation? So in this situation, we should not stop this drug. Rather, we will advise or prescribe this drug in a sustained form. So in case of sustained form, the drug will release very slowly, and usually these kind of complications would not be happened. And another complication is reduced vitamin B12 absorption, and very rare complication but very important for exam, that is the lactic acidosis, especially if this patient has liver failure, heart failure or renal failure. And the fourth one is increased risk of contrast nephropathy. So before the contrast nephropathy, before the use of contrast, we have to stop this metformin at least 2 days before. So these are the very common complications of metformin, and it is very important for the part 1 exam and also for the part 2 exam. So what are the contraindications for this metformin? That is, if this patient has renal failure, hepatic or heart failure, then there will be very good chance of having lactic acidosis. If this patient's creatinine is more than 130, then we have to reevaluate of this metformin. We can reduce the dose. And in case of if the creatinine is more than 150 or GFR is less than 30, then we have to stop this metformin. And in case of recent MI, we have to stop this metformin at least for 6 weeks. And also alcohol abuse is a relative contraindications. And in case of general anesthesia and contrast media use, then we have to stop this metformin at least before 2 days. And after the procedure, we can restart this metformin if the renal function is normal. Okay. Next come to the sulfonylurea. We know that sulfonylurea is a secretagogue. That means it will increase the insulin secretion from the beta cell of the pancreas, and it will act on the ATP dependent potassium channel as like the thiazolidinide ion. And the very important side effect is hypoglycemic episode, very common, and weight gain. There are also other rare side effects but important for exam, that is SIAD, bone marrow suppression, cholestatic liver damage, photosensitivity, peripheral neuropathy, and in case of glucose 6-phosphate deficiency, hemolysis. So it's very common for the exam, that suppose like any patient is taking sulfonylurea for diabetic control, and this patient has a features of hemolysis like anemia and jaundice, so it is very expected that this patient may have glucose 6 phosphate deficiency, and for this sulfonylurea it will cause hemolysis of this blood. Now come to the thiazolidinedione. In thiazolidinedione, actually it is not used in current era because of some side effects, but it is important for exam because to know the side effects. And the mechanism of action is it will act in the PPAR gamma receptor agonist. So it will act as a PPAR gamma receptor agonist. Importantly, PPAR alpha agonist is fenofibrate. So you have to know and you have to correlate with them. Okay, so what are the side effects actually? That's why it's not used right now. Is that the number one is weight gain, and the fluid retention is very important, and it is very good chance of this patient to have heart failure for this drug. So in case of heart problem, we must not use this drug. Okay, and liver impairment is another complications, and this may cause osteoporosis and subsequently osteoporotic fracture of this patient, and another is bladder cancer. So these are the main complications, especially with the heart failure. For this reason, this drug is not used right now. Okay, now the important drug, that is the exynotite or liraglutide, that is the GLP-1 mimetics. We know that when we take meal, when it will enter the stomach, it will give the signal that that the food is in the stomach. Then from the intestine, that will release some hormone, that is the glucagon like peptide, and this glucagon like peptide will stimulate the beta cell of the pancreas to secrete the insulin. So this is the normal physiology, and from this normal physiology, this drugs is arranged that this drugs is available, that is the exynotide or liraglutide. These are the GLP-1 analog or mimetics. So it will enhance the physiological process of our body. So what's the action? It will increase the insulin secretion and inhibit glucagon secretion by the liver, and importantly, it will suppress the appetite and slow the gastric emptying. So it is very it has contraindication with the gastroparesis of this patient. You know that in case of diabetes, gastroparesis is a very common complications. So if this patient has gastroparesis or GERD, then it is important that we should not use this drug. But it will not increase the insulin sensitivity because it will just increase the insulin secretion, and it should be taken 30 minutes before the meal as like the insulin, and it has no chance of hypoglycemia, so self monitor is not necessary by the glucometer, and it can be used in combination with metformin, sulfonylurea or thiazolidinedione, but not should be with insulin. And its important action is to weight loss, because it is should be used in the patient where insulin should be very where insulin usage is very likely, or patient has very obesity. If BMI is more than 35, then this drug is a very good option and it will reduce the weight. So it's very important, that is it has the weight lossing properties. Okay, now come to the another drug, that is the SGLT2 inhibitors, that is the empagliflozin or dapagliflozin, like this. This drug is now used in case of heart failure. We know that in case of heart failure, in recent guideline, there are 4 drugs actually now are used. Like the first line is sacubitril valsartan, then spironolactone, then beta blocker like bisoprolol or carbidiolol, and the fourth drug should be SGLT2 inhibitors. So this drug is very good drug for heart failure patient, and it will improve the mortality. So reduce the cardiovascular events like stroke, MI, or heart failure, very important, and increase that. But it has property to increase the total cholesterol level, and it will increase the risk of lower limb amputations because of small bone fracture. And as this drug actually will work in the nephron to pass the glucose through the urine, and subsequently it will reduce the blood sugar. As this will increase the will increase the sugar in the urine, so it will be very normal or very common for this drug to increase the risk of genital infection. And importantly, this drug will increase the risk of euglycemic decay. That means patient has decay but blood sugar is normal. Okay, in case of new guideline we have told, okay, now come to the DPP4 inhibitor. DPP4 inhibitor is a very excellent drug nowadays because it's just like metformin will not increase the weight of this patient, and it has oral preparation, and we can give it with combinations with metformin or sulfonylurea, especially for the drivers. If you get any question in the exam with about the blood pressure control of a bus driver, then DPP4 inhibitor is a very good option because it will not increase the weight, and additionally it will not cause hypoglycemia. So, and the mechanism is that in case of we normal physiology, we know that when the food in the stomach, then glucagon like peptide 1 will be secreted from the intestine, and it will stimulate the beta cell of the pancreas to increase the or secrete the insulin. But this GLP-1 will degraded by the DPP4. So if we can use DPP4 inhibitor, then the action of the GLP-1 will be increased. So this is the mechanism of this drug. So these are the drugs actually we can use on diabetic patient. In the next session, we will learn about maturity onset diabetes mellitus of the young. Thank you so much. See you in the next session.